Over the years, when I worked at St. Thomas's Hospital and St. John's Hospital for diseases of the skin, I developed an interest in squamous cell carcinoma arising in recessive dystrophic epidermolysis bullosa patients. I worked with Professor John McGrath and Robin Eady, and it was very, very interesting that over the space of about 10 years, I must have seen hundreds of and hundreds of tumors. And this is largely because it's such a common complication of recessive dystrophic EB. I think it's estimated that probably all patients will develop tumors, and the vast majority of patients will develop multiple tumors. And while they're well differentiated tumors histologically, they're very aggressive, and the majority of patients eventually die as a consequence of their squamous carcinoma rather than anything directly related to blistering. Now, just to remind you, epidermolysis bullosa is an inherited condition whereby the skin is susceptible to very mild trauma, particularly shearing trauma, which results in subepidermal blistering. And there are four major types: simplex junctional dystrophic and Kindler syndrome. But if you characterize the disease further by the genes affected, by the distribution of lesions, whether or not there's mucosal involvement, and so on, there are about 20 subtypes. But I don't really want to get into that too much. I just want to really make this talk about the tumors. Anyway, patients with recessive dystrophic disease can sometimes have more localized blisters, but in general, the blisters are widespread, and the patients, as a consequence of ulceration and inflammation, develop scarring and sometimes very severe contractures. Recessive dystrophic EB develops as a consequence of mutations in COL7A1, which is the gene that is responsible for type 7 collagen. And there's a varying degree of effect of the mutation, so that in some patients you might just see reduced anchoring fibrils, but in the majority one notices a complete absence of anchoring fibrils. And type 7 collagen is essentially what holds the epidermis onto the dermis. So when you have a mutation of type 7 collagen, the epidermis readily separates from the dermis to give a cell-free subepidermal blister. And in some patients, you may see digital autoamputation, and in some patients, mucosal involvement is present. And I note down here at the bottom that 87% of patients with recessive dystrophic EB die from their tumors by 45 years of age, and that's from a series in the USA. Now, this is a very useful diagram which I borrowed from Condorelli's article, and it's an overview of the different proteins that may be affected in the different subtypes of epidermolysis bullosa. And I'm not going to talk about any of those because it's not relevant to this talk. Really what we're thinking about is dystrophic EB, which, as I mentioned, is a collagen 7 gene mutation. There's a useful little arrow on the slide which shows the risk of developing squamous cell carcinoma, and it's not just in recessive dystrophic, but the risk increases very, very markedly as you extend from basal epidermolysis bullosa simplex through junctional and into type 7 collagen. I think in one patient we saw a melanoma, but I've no idea whether that was related to the EB or whether it was due to sunlight or whatever. Now, this is another useful table that I got from Condoretti's article, and it's comparing patients with recessive dystrophic EB and skin cancer versus skin cancer arising in patients who do not have epidermolysis bullosa. And it's interesting that pretty much the same genes are affected in both sunlight-induced skin cancer and in EB-related diseases. Particularly, for example, you can see that Notch1, TP53, and CDKN2A match up quite nicely between dystrophic EB and EB-related skin cancer. And basically, the pathogenesis appears to be particularly related to inactivating mutations in Notch1, in patients with Notch1 mutations. And I'm going to show you a few clinical slides of these tumors. This is a patient with very long-standing EB, and you can see the skin is tremendously scarred with a very prominent superficial vasculature, and there are two ulcerated tumors. This is a close-up of a view from the forearm, and in fact most of these tumors are present on the limbs, and I think that's just a reflection of limbs are much easier to traumatize than, say, the abdomen and back and so on. And then this is an interesting patient. Patients with EB develop autoamputation due to the contractures, and you can see the digits are pretty much absent, and the skin grows around the distal limb, and it gives you this mitten type deformity, which is terrible affliction. And then the other problem is patients develop keratoses, and there's a nice big one there, and it's very hard clinically to know whether that's just a keratosis characterized by massive hyperkeratosis, irregular acanthosis, and scarring in the absence of any evidence of tumor formation through to lesions like this, which are very, very obviously squamous carcinoma when you look at them down the microscope. And one of the things I found, because I used to visit the patients to get to know them, and there was one patient that I met, and she said that she always knew whether something was just a keratosis or whether it was a squamous carcinoma, and she would say, I want that one biopsied, but not that one. Which is quite extraordinary, but it seemed to be be a reasonably good indicator. And here we see a patient with autoamputation and loss of the digit on that finger. And over here we've got a fracture, and then you can see the outline of tumors as well. And there's another patient showing tremendous scarring, multiple tumors. One, well, I mean, this is, I don't know whether this is one tumor or tumors coalescing, but it's a huge thing anyway. And there's another one there, there's another one there. And you can see the background scarring and notice the autoamputation. And then this was an interesting patient. It was a young lady, and she was known to have epidermolysis bullosa. And she's one of those patients that just seemed to slip through the cracks, and I don't quite know how. But anyway, she ended up getting treated by local health services, I can put it that way, rather than by her doctor or dermatologist. And so as a result of that, she had endless talcum powder deposits on her skin, thinking that that might make it better, which it clearly didn't. And eventually the patient, I suppose, had had enough of it and went to see her GP, who then said, "Oh my gosh, I'll send you straight to hospital." And this whole thing, the whole thing is squamous cell carcinoma, absolutely hideous tumor. Now, I just wanted to remind you of the histology of recessive dystrophic epidermolysis bullosa, and I mentioned to you that it's a sharing type of trauma, and so because the defect is so severe, the mere effect of putting a scalpel down on the skin results in sharing, and so this is really probably a result of the procedure rather than necessarily representing a blister being biopsied. But you'll notice the epidermis, the basal there, very clearly outlined, and then the dermal papillae presenting a stretched structures with a bit of chronic inflammation. But you'll notice the blister cavity is completely cell-free, and there's a close-up view there of the dermal papillae. And very often, if you get a biopsy of an evolving lesion, you'll see a subepidermal blister, and then there's massive scarring of the underlying dermis. And this is electron microscopy of a patient with recessive dystrophic EB. Now, just to orientate you, the cell membrane and hemidesmosomes are visible as you work your way along, but underneath the lamina densa, you'll notice there are possibly two anchoring fibrils there, but basically if you work your way along the lamina densa, as I'm doing with the cursor, there are no anchoring fibrils other than those two. Maybe that's one there, but basically they are very much reduced in number to almost absent. So that's electron microscopy of recessive dystrophic EB. And this is a typical tumor. The tumors are basically, they're nearly all well differentiated squamous cell carcinomas, which in a non-EB patient would not be such a problem. But for some reason, and I really can't get into that, it gets way too complicated and beyond the scope of this talk. These tumors are, you'd have to say they are very high grade. They recur almost invariably they metastasize widely, and as I mentioned earlier, the majority, if not all, of patients eventually succumb to these tumors. The one on the right was an interesting, unusual one. This was a verrucous carcinoma arising in an EB patient. And as you see there, it's well differentiated. There's obviously keratinization. And this was a strange one. I can't remember too much about it, other than it was one of the patients in our series, and she developed this funny tumor, which at first sight I thought was going to turn out to be a vascular tumor, maybe even a lymphangiosarcoma, because of all these empty spaces. But and there's a close-up view there, and you would be quite, I think you'd be very hard put to call that a squamous carcinoma unless you did some immunohistochemistry, and there's keratin. So this was classified as a pseudovascular squamous cell carcinoma. And then lastly, just to remind you, the overwhelming majority of patients with recessive dystrophic epidermolysis bullosa develop multiple high-grade tumors, which probably in all patients eventually kills them. So I hope that's of some interest to you, and if you have any questions, please ask them. I'll be happy to try to answer. So thank you very much for your time.